we couldn't go any far less technologically advanced compared to what you guys have seen. So I want to thank our session chairs. I want to thank the Sagem's Program Committee. And we're going to talk about something that will address a clinical problem that our patients face every day, every year, and something that I think will probably change the way that we do intestinal surgery. These are our disclosures. I will say that we have been funded by a Case Western internal Coulter Translational Research Partnership. So diverting loop ileostomies, for those of you that do abdominal surgery, somewhere along the way you might have performed this procedure. For those that don't do surgery, this is basically a connection of the intestine to the skin to allow the stool to come out and not pass throughout the entire GI tract. And it's temporary, all right? Normally what happens is the patients have a second surgery later on. This procedure is performed somewhere between 100 to 200,000 times per year, and that second surgery is not without complications. Bleeding, leakage, and all the things that come with a second operation. And it usually is about 3 to 6 months after the initial surgery that patients go on. So they have to live with this ileostomy that they've been given until, let's say, they've completed their chemotherapy regimen or they've healed up their prior surgery and such. And there are complications that come with this. This is the hernia that I fixed on Tuesday, okay, from a stoma takedown that had been performed about 6 months previously. So this device that we have created, again, it's low fidelity, but it was addressing a problem that I thought was necessary. It is a spontaneously closing reversible stoma that does not require a second operation. We are still in animal models right now. When we look at this device, it basically is a cuff tube that has a highly compliant, low radial force balloon and a proprietary sleeve that it's attached to provide temporary diversion. When we look at let me see if I can get the mouse. See, this is how technologically unadvanced I am, okay? Can you get the video to play? Is there someone back there? Because I'm not getting, there you go. So this is done at the time of a laparotomy. So think of a lap J tube or an open J tube, but instead of going distally, we're going proximally, all right? And like a stam J or a stam gastrostomy, the bowel is brought up to the abdominal wall. You can imagine different lengths for patients that are morbidly obese, where it's very difficult to bring up a loop ileostomy, similar to a tracheostomy tube, okay? They're different sizes and lengths. And we'll go ahead and place that, okay? Let's advance from there. The device is implanted, as I said, at the time of surgery. We are unable to put a colostomy bag on a patient that is a porcine model, okay, and a quadruped. And basically we would collect stool, we'd have them in the pens every day and put chucks underneath them and we would weigh them. So when we moved along, can you play the video again, please? This is a retrograde contrast study through the device that you can see filling the proximal small bowel, the proximal end of the cuff, but not passing along the cuff, showing complete obstruction distally with proximal filling. Go ahead, play another video. I told you, this couldn't get any further away from what you've seen these last 6 videos, okay, from the other presenters. This is the stomal diversion in an animal, okay, and they're very comfortable. They walk around in their skirts, and they have the device hanging in there, and they pass stool, and we measure it, okay, underneath the cage. And this is what the animal unfortunately looks like, okay? On the left picture, you can see the excoriation of the abdominal wall. At 7 days, we take the device out, and there's a hole, okay? And on the right, this is what it looks like 3 days later, okay? The excoriations are gone, the hole is closed, and this is without any surgical intervention. Think of a PEG tube, think of a J tube, think of any foreign body that we put into the GI tract and we remove. When we compared this to a control model of an actual loop ileostomy, on the left between the blue and the red, you can see that the amount of succus that was coming out through the device was similar, okay? And in fact, our device, I don't know why, just based on what the animal ate, I guess, along the way, in fact, produced more, okay? And so we showed that we provided diversion. When we explanted the animals, okay, at 28 to 35 days, there was no mucosal or any small bowel injuries that were related to the device implantation. In conclusion, basically, our device is placed either at a time of laparoscopy or open surgery, outpatient removal. Think of being in your office, you take the device out, okay, and they don't require a second operation. And this spontaneously closes and allows us to get our patients through things without interruption of their chemotherapy, without requiring a second operation, and without all the complications and consequences that comes with that. And I do believe this is going to change the way, and it's a paradigm shift in how we will approach intestinal surgery. And Sally here says thank you as she walks around her pen with her diverting stoma device. Thank you very much.